Have you ever wondered what's really going on inside a doctor's head during one of those high-stakes, life-or-death decisions? Well, it's not some kind of magic, it's a mental framework. And in this explainer, we're going to pull back the curtain and unpack the exact clinical reasoning that guides these professionals when everything is on the line.
All right, let's just dive right in. I want you to imagine you're in the ER. A patient gets wheeled in. They're clutching their chest, clearly in distress. The clock is ticking. You have minutes, literally minutes to act. This is absolutely not the time for guesswork. It's time for a protocol, one that has to be executed with almost military precision.
So how do clinicians actually handle that kind of pressure? Well, here's the secret. They don't improvise. When it comes to a potential heart attack, they follow a super rigid, non-negotiable checklist. It's designed for one reason and one reason only, to prevent catastrophic, life-ending errors.
And this right here, this is that checklist. The details are what matter. So within those first 10 minutes, you have to get an ECG to see what the heart's doing. Delay that, and you delay the diagnosis. The patient has to chew, not swallow, chew 325 milligrams of aspirin for the fastest possible absorption. You also have to ask, and this is crucial, if they've taken drugs like Viagra. Why? Because if you give them nitrates, their blood pressure could plummet fatally. And finally, you get an IV line in for easy access. Missing any one of these steps, well, it isn't just a simple mistake. It's what's known in the field as a never event, something that should never happen.
Okay, so once that immediate danger is under control, the whole game changes. The clinician's role completely shifts, the pace slows down, and it goes from this frantic emergency response to more of an intellectual puzzle. It's time to start thinking like a detective.
Let's take something way more common, an itchy rash. To most of us, a rash is a rash, right? They all kind of look the same. But to a clinician, they're packed with clues. Is it dry, red, and hiding in the crooks of the elbows and knees? That's pointing straight towards eczema. But what if the itch is 1,000 times worse at night, and you see these tiny little burrows between the fingers? That just screams scabies. See? The diagnosis is all in the details.
So this detective work, it actually has a formal name. It's called a differential diagnosis. And the key word here is systematic. It's all about creating this list of every single possibility, and then, one by one, methodically ruling things in or out based on the evidence you gather. This is the absolute core of the diagnostic mindset.
And how do you start crossing things off that list? Simple. You ask the right questions. When did this thing start? Does anything make it worse? Is that itch way worse at night? That's that classic clue for scabies we were talking about. Does anyone else at home have it? Every single answer is another piece of the puzzle, helping that clinician zero in on what's really going on.
But what happens when a tool you've trusted for your entire career is suddenly gone? This brings us to a really crucial part of the clinical mindset, which is that nothing, and I mean nothing, is ever set in stone. You have to be ready to question everything you think you know.
So for decades, there was this drug called ranitidine. You probably know it as Rantac. It was one of the most common drugs on the planet for things like heartburn and gastritis. It was considered totally safe, super effective, and it was a staple in every single clinician's toolkit, a real go-to.
And then, almost overnight, it was gone. In 2019, they found that the drug was contaminated with something called NDMA, a probable carcinogen. By 2020, it was pulled from shelves all over the world. Now, it's not even recommended. It's just a stunning example of how fast medical science can change, forcing clinicians to constantly be learning and updating their knowledge base.
And hey, if you already knew about this whole recall, give yourself a pat on the back. Seriously. As our source material puts it, excellent reasoning if you spotted the recall. It means you're already thinking like a modern clinician, because staying current isn't just a good idea, it's absolutely non-negotiable.
Now, that need to adapt your thinking doesn't just apply to new evidence. It applies to different patients. And nowhere is this more true than in pediatrics. Because a core principle of pediatric medicine is this: children are not just small adults.
So what's with this number? 0.15 milligrams per kilogram. Well, that is the precise weight-based dose for the anti-nausea drug ondansetron in a child. It's not about 0.1, it's not an estimate, it is 0.15 milligrams for every single kilogram of that child's body weight. In pediatrics, that kind of precision isn't just good practice, it can literally be the difference between life and death.
And this slide right here really drives that point home. In an adult with, say, traveler's diarrhea, you might use a drug like loperamide to slow things down. No big deal. But if you give that exact same drug to a child under 2, whoa, it is strictly forbidden. It can cause a life-threatening paralysis of their gut. You've got the same symptom, but a completely different, and in this case, incredibly dangerous treatment plan.
The stakes are just so incredibly high. Remember that term, a never event? It's a medical error that is so serious it should never, ever happen. Well, in pediatrics, letting a dehydrated child get so sick that they go into shock is one of them. And this is why adapting treatments, like knowing to avoid certain drugs in kids, is just so unbelievably critical.
Okay, so we've looked at emergency checklists, we've done some diagnostic detective work, we've seen how you have to adapt to new evidence, and we've touched on the huge differences in pediatric care. How does this all come together? Well, let's zoom out and look at the final blueprint for this whole way of thinking.
This is it. This is the framework. It all starts with first principles, just basic human physiology. Then you're looking for red flags, those immediate danger signs like we saw with chest pain. Third is diagnostics. That's the detective work, building your list of possibilities. Fourth, you move to management, creating a plan based on the best evidence, whether that's choosing an antibiotic or remembering a drug was recalled. And finally, wrapping around everything is safety, constantly asking, how can I prevent an error here?
But please, don't think of this as some static checklist that you just run through once and you're done. It's not like that at all. It's a dynamic, looping mental framework. A good clinician is constantly cycling through these steps, reevaluating and adjusting as new information comes in. This is the mental model that allows them to navigate the inherent chaos and uncertainty of medicine and ultimately to save lives.
And there you have it. That's a peek inside the clinical mindset. It's this incredible blend of rigid protocols and creative problem solving, of continuous learning and constant vigilant awareness. So, I'll leave you with this question. What's the biggest misconception about how doctors think that this clears up for you? Thanks for tuning in.